Hello, my name is Rachel Solnick, and thank you for your interest in this talk on a national study of expedited partner therapy in academic emergency departments. So to begin with, emergency departments are actually a hotspot in the STI public health crisis. CDC reports that in the past year, has been historic high counts of chlamydia, actually more than has ever been previously recorded. And in 2019, there was a total of 2.5 million cases of gonorrhea, chlamydia, and syphilis, representing a 63% increase in gonorrhea. And estimates are actually that in 2018, 1 in 5 Americans had an STI at any point. And emergency departments are actually a hotspot for STIs. According to CDC data from 2018, they in general diagnose a similar percentage of national cases of gonorrhea compared to STI clinics. And those who are positive for chlamydia actually have a higher likelihood of reporting that they use the emergency department for their usual source of care compared to those who are more likely to use doctor's offices as the usual source of care. And STIs in the ED are actually a matter of sexual health equity. Minorities, women, low-income patients, as well as those who have poor healthcare access, face a higher burden of STIs. And these are actually groups that are often more likely to use the ED for their STI care. And so this is where expedited partner therapy comes in. Expedited partner therapy arose out of a status quo fail, the fact that partner notification, essentially telling patients to notify their partner of their exposure, is inadequate. And in some studies of high morbidity STI areas, partner notification actually only reached 12 to 17% of patients. And EPT is the process, expedited partner therapy is the process of treating sex partners of patients who have STIs without an intervening exam. And it's used in cases in which the partner will not seek care otherwise. So it's more of like a harm reduction approach to treating STIs. And as you can see on the diagram on the right of the screen, it cuts out a lot of the potential barriers that would prevent a partner from actually getting treatment with all of the intervening healthcare access steps. And it's legally protected and or permissible in all states in the US. And it's also supported by some of our physician organizations such as ACEP, the CDC, the American Bar Association, etc. So the research goals of this study was to characterize emergency department medical directors as well as key informants, their perspectives on the barriers and facilitators to the implementation of expedited partner therapy in emergency departments. We looked at both high performers here, operationalized as those who were using EPT, to understand the strategies and mechanisms by which they implemented EPT, as well as lower performers, those who were interested but not yet actually using EPT, to understand what sort of individual as well as local factors might be preventing implementation. We used a mixed methods approach, the first part of which was a survey that is reported in a different study, followed up by semi-structured interviews, which I'm about to talk about in the next slides. We used the AAAEM benchmarking group survey of academic emergency departments to survey which across the nation of the emergency departments had already implemented EPT, or those who were interested, and we selected those based off those survey results and followed up with these interviews based off of CFR, the Consolidated Framework for Implementation Research. We transcribed, coded, and used thematic analysis, again using the CFR codes as a code book, as well as inductive codes arising from the interviews. The participant characteristics of our interviews were mostly medical directors with a few nurse, pharmacists, resident, and program directors selected by snowball sampling. They were mostly male, and they were representative from all census regions, a little bit more so from the Northeast and the Midwest, about 33%. And so I'm going to go through the next slides, some of the major themes that we found from the interviews, going one by one through these. The first one starting with this idea of a compatibility clash, this tension between the social emergency medicine mission versus the idea of the non-urgency, or in some cases, just local low needs of STI care from the emergency department. Some of the quotes from this were, the idea that we're the glue that pulls together this broken system. But then contrastingly, this quote that no one goes into emergency medicine to stamp out STIs. The next theme was the idea of complexity of this non-traditional care process, presenting legal safety as well as EMR issues. And so one of the EMR issues was the obstacle of Epic. Someone said that nothing in Epic is easy, and talking about how it was difficult to prescribe for a patient that was not in the system. Other parts of like the patient safety part was this idea of diagnostic inaccuracy of the empiric treatment, potentially being compounded by spreading that to the partner. And then lastly, this idea of the legal issues, even though it's legally protected in some states, people thought that's just because, here's a quote, that just because there's a law doesn't mean someone can't sue you. The next theme was a lack of awareness, which was in some cases in the high performers able to be overcome by streamlined processes and task delegation. One quote from this was, if it takes 10 minutes to figure out, I'm not going to do it. And then another quote from somebody who was able to use their EMR, leverage that to overcome some of these difficulties in this prescription, was that they used the Epic workflow to essentially automate it. And the quote from there was, it takes a lot of the memorization about how to do this process. The next theme was this idea of stigma around sex. We were surprised as researchers to see in a number of interviews, people that the medical directors felt that that was a potential obstacle towards implementation of EPT. One quote was, providers don't necessarily feel comfortable at times asking about people's sexual history. And then lastly, we found that champions were able to overcome some of the self-efficacy blocks or other sort of institutional blocks in EPT. One of the quotes was, I'm just a cog in the wheel. And that was from a medical director who felt that even though they were in a position of potential authority, it wasn't actually enough to overcome some of the local barriers. But then contrastingly, another medical director felt that we can champion these really important causes, thinking about how in their position of power, they were actually able to help move the department towards a system which did EPT. And so that's all I have right now. As you can see, my contact is on this slide, and I welcome any questions via email or Twitter. Thank you.